Hello, and welcome to Study Neuro, your neurosurgical teaching series focused on making neuroscience and clinical neurology clear, practical, and easy to apply in real clinical settings. In today's session, we will discuss clinical manifestations of degenerative cervical myelopathy, or DCM, symptoms, neurological signs, and functional impairment. This topic is important because DCM is the most common cause of spinal cord dysfunction in adults, and early symptoms are often subtle and easily missed in routine clinical evaluation. Our aim is to build a practical understanding of how cervical myelopathy presents in patients and how progressive spinal cord compression leads to neurological dysfunction over time. By the end of this session, you should be able to describe the common clinical manifestations of DCM, recognize both early and advanced disease features, and identify key neurological examination findings. You should also understand how spinal cord compression translates into functional impairment and how to distinguish myelopathy from isolated cervical radiculopathy using clinical features. Before we begin, stay connected with the Study Neuro community for concise neuroscience education, neurosurgical insights, and evidence-based clinical learning. Follow Study Neuro across our social media platforms for new lectures, case discussions, and practical teaching content for students, trainees, and clinicians. Thank you for being part of this learning journey. Let's get started.
Degenerative cervical myelopathy is a condition caused by chronic compression of the cervical spinal cord. It is the most common cause of spinal cord dysfunction in adults seen in clinical practice, and it is most often seen after the age of 40, with a higher frequency in men compared to women in roughly a 3-to-2 ratio. The clinical presentation varies widely depending on the degree and duration of compression. Some patients present with mild hand symptoms, while others develop clear gait disturbance and progressive loss of function. Early signs are often subtle and may be missed during routine assessment, which can delay diagnosis and allow neurological injury to progress. These early changes are important and should not be overlooked. Early recognition is critical because once spinal cord damage becomes established, recovery may be incomplete even after treatment. Identifying the condition early offers the best chance of preserving neurological function and preventing long-term disability. Timing makes a real difference.
The clinical spectrum of degenerative cervical myelopathy is broad and reflects how differently the spinal cord responds to chronic compression across patients. Symptoms may begin with mild sensory changes and progress to significant disability, affecting mobility and independence over time. It does not present in a single fixed pattern. Some patients experience slow, steady progression, while others may deteriorate rapidly after relatively minor trauma. In certain cases, imaging may show marked spinal cord compression with only minimal symptoms, creating a mismatch between radiological findings and clinical presentation that can complicate assessment. Careful clinical correlation is always required. Overall presentation depends on the severity and duration of compression, the level of spinal cord involvement, and whether adjacent nerve roots are also affected. These interacting factors shape the final clinical picture in each patient. No two cases are exactly the same. Early clinical symptoms of cervical spinal cord compression often begin subtly, affecting the sensory and motor function of the hands in a way that patients may initially ignore or misinterpret. The changes are often easy to miss. Patients commonly notice problems with hand coordination, such as struggling to button clothes or write clearly, because reduced dexterity and mild clumsiness interfere with everyday fine motor tasks over time. Daily activities gradually become more difficult. Sensory changes in cervical cord dysfunction often present in a diffuse pattern rather than following a single nerve root distribution, meaning patients may feel abnormal sensations in the hands and upper limbs that do not match a clear anatomical line. This pattern is often confusing. These symptoms can include tingling in both hands, widespread numbness across the upper limbs, reduced awareness of joint position, and weakened ability to feel vibration or distinguish pain and temperature, all reflecting disrupted sensory pathways within the spinal cord rather than a peripheral nerve problem. The deficits may affect one side of the body or both, and this variability often depends on the level and severity of cord involvement, which can change how symptoms appear during daily function and clinical examination. Findings can shift over time. In practice, clinicians may see uneven sensory loss involving either side or both sides in the same patient, and this inconsistency next to the diffuse pattern is a key clue pointing towards central spinal cord disease rather than localized peripheral injury. Hand dysfunction is one of the most recognizable features of degenerative cervical myelopathy, and it reflects early disruption of the fine motor control pathways within the spinal cord that coordinate precise finger and hand activity. This is clinically important. Patients often lose smooth control of small, rapid hand actions, with reduced grip coordination and difficulty performing quick alternating movements, which together signal a decline in manual precision that is not explained by muscle strength alone. In daily life, this shows up in very practical ways that patients notice first, such as struggling to use keys, handling small objects like coins, or producing steady handwriting during routine tasks that once felt automatic and effortless. Small tasks become frustrating. These changes often progress slowly, and next to weakness or sensory symptoms, they strongly suggest an underlying cervical cord process affecting skilled hand function rather than a simple peripheral nerve problem. Motor dysfunction in degenerative cervical myelopathy develops as progressive compression of the spinal cord disrupts the descending motor pathways that control both upper and lower limb movement. This is a central process. Patients may present with weakness in the arms and legs, along with reduced coordination and early fatigue during walking, which together reflect impaired signal transmission rather than isolated muscle disease. As the condition progresses, these motor changes begin to affect daily function more clearly, with routine activities becoming harder to complete and overall independence gradually declining in a stepwise and sometimes unpredictable manner. Function starts to slip. Clinically, this progression next to coordination loss signals advancing spinal cord compromise that requires careful monitoring and timely intervention to prevent further functional deterioration. Gait disturbance in advanced degenerative cervical myelopathy reflects impaired control of posture and walking, where patients begin to walk in an unsteady and often widened pattern because the spinal cord can no longer coordinate normal lower limb movement effectively. This is an important warning sign. The imbalance is not random, and it usually comes from a combination of spastic muscle tone, reduced joint position sense, and disruption of corticospinal pathways, which together disturb smooth and stable walking, even on flat ground. As the condition progresses, patients may start to stumble more frequently and experience falls during routine activities, especially when turning or walking in low light, where balance demands are higher and compensatory mechanisms are less effective. Falls become more likely. Next to these clinical features, the underlying problem is central nervous system dysfunction, where impaired sensory feedback and motor control interact in a way that steadily reduces gait stability and overall mobility. Spasticity in degenerative cervical myelopathy reflects upper motor neuron involvement caused by chronic spinal cord compression, leading to abnormal increase in muscle tone and reduced voluntary control of movement. This is a key neurological pattern. Patients typically develop stiffness in the lower limbs with a spastic gait that feels tight and effortful, alongside reduced mobility that limits smooth and coordinated movement during walking. Clinically, this translates into clear functional problems, such as difficulty climbing stairs, reduced ability to walk long distances without fatigue, and worsening balance that affects stability during routine activities and daily movement. Movement becomes restricted. Next to these motor signs, the overall picture suggests progressive corticospinal tract dysfunction, where impaired inhibitory control from the brain leads to excessive muscle activation and steadily declining functional capacity.
Autonomic dysfunction in advanced degenerative cervical myelopathy occurs when spinal cord compression extends to the pathways that regulate bladder and bowel control, disrupting normal involuntary function that is usually well coordinated. This is a late and important sign. Patients may develop bladder control problems such as urgency, increased frequency of urination, and, in more advanced cases, episodes of incontinence that reflect loss of normal storage and emptying regulation. Bowel function can also be affected, with symptoms ranging from constipation to sudden urgency, and in severe late disease, there may be loss of bowel control, which strongly suggests significant and long-standing cord involvement. Control becomes unreliable. Next to these features, the presence of autonomic symptoms generally indicates advanced neurological compromise, where multiple spinal cord pathways are affected beyond just motor and sensory systems, signaling a more severe stage of disease progression. Sexual dysfunction is a recognized but often underreported feature of cervical myelopathy. It can occur when spinal cord compression affects pathways involved in autonomic and sensory function. This symptom may provide important information about disease severity. Patients may notice a reduced interest in sexual activity, difficulty achieving or maintaining sexual performance, or a decline in overall sexual satisfaction. In men, erectile dysfunction can occur, while both men and women may experience reduced genital sensation or difficulty reaching orgasm. These symptoms can have a significant effect on quality of life. Because patients may hesitate to discuss sexual concerns, clinicians should ask about them when assessing cervical myelopathy. Careful evaluation helps identify autonomic involvement and provides a more complete picture of the patient's neurological function. Reflex abnormalities are a common finding in degenerative cervical myelopathy and usually appear during routine neurological examination when the examiner assesses the integrity of the spinal reflex pathways. This is a classic upper motor neuron sign. Patients typically show brisk reflex responses in both the upper and lower limbs, where simple tendon tapping produces a response that is stronger and more sustained than expected. These exaggerated reflexes reflect dysfunction of the corticospinal tracts, where the normal descending inhibitory signals from the brain are reduced, allowing spinal reflex circuits to become overactive and less controlled. Control is essentially lost. Next to these findings, the overall pattern points towards central nervous system involvement rather than peripheral nerve disease, and it often helps confirm the diagnosis when combined with other signs of myelopathy. Pathological reflexes are important upper motor neuron signs that appear when the normal inhibitory control from the brain over spinal reflex circuits is disrupted, and they are often used to support a diagnosis of cervical myelopathy during clinical examination. These are strong diagnostic clues. One example is a finger flexion response when the distal phalanx is flicked, which indicates abnormal corticospinal tract activity rather than normal reflex behavior. Another classic finding is an upgoing plantar response, where stimulation of the sole produces extension of the big toe instead of the expected flexion, reflecting loss of normal descending control pathways. This is not normal. Clonus may also be present, seen as repetitive rhythmic muscle contractions triggered by a sudden stretch, which points to an overactive spinal reflex system due to impaired inhibition from the central nervous system. The inverted brachioradialis reflex is a special clinical sign that can appear in patients with cervical spinal cord compression, particularly around the C5 to C6 level, where normal reflex pathways are disrupted and replaced by abnormal response patterns. This is a subtle but useful finding. Normally, tapping the brachioradialis tendon produces contraction of the brachioradialis muscle, but in this condition, the expected response is lost, and instead there is finger flexion, which reflects spread of the reflex to neighboring flexor pathways. This abnormal response is significant because it suggests cervical cord involvement rather than a simple peripheral nerve problem, and it becomes especially helpful in cases where radiculopathy and myelopathy occur together, making the clinical picture more complex and sometimes harder to separate. It adds diagnostic clarity. Several other clinical signs can help identify cervical myelopathy during examination. Some of these findings reflect irritation of the cervical spinal cord, while others reveal dysfunction of the upper motor neuron pathways. These signs can be subtle. One example is Lermit sign, which is an electric shock-like sensation that travels down the spine and sometimes into the limbs when the neck is flexed. This finding suggests irritation of the cervical cord. Visible wasting of the thenar eminence may also be present, indicating loss of muscle bulk at the base of the thumb due to chronic neurological involvement. Certain reflex changes are also important. Tromner sign occurs when tapping the distal middle finger triggers flexion of the thumb or index finger, while a crossed radial reflex is present when testing the brachioradialis reflex produces contraction beyond the expected muscles, extending into the biceps or wrist flexors. These are useful clues. Another sign is the finger escape sign. When the fingers are held extended, the ring and little fingers gradually drift into flexion and abduction, reflecting impaired hand motor control from cervical cord dysfunction. Degenerative cervical myelopathy is usually a slowly progressive condition, but neurological status can change quickly when the already compressed spinal cord is exposed to additional stress or injury. This is clinically important. Even minor trauma, especially neck hyperextension, can tip a compensated state into sudden deterioration, and patients with congenital spinal canal narrowing are particularly at risk because they have less space to tolerate further cord compression. When this happens, neurological decline can be rapid, with worsening limb weakness, more pronounced difficulty with walking, and a noticeable loss of hand function that affects daily tasks that were previously manageable, sometimes within a short period of time. Deterioration can feel sudden. Next to this pattern, the key concern is that a relatively stable chronic condition can shift into an acute neurological deficit, making early recognition and prevention of minor injury especially important in clinical management. In conclusion, degenerative cervical myelopathy is a condition with a wide clinical spectrum where patients may present with a mix of sensory, motor, and functional changes that reflect progressive spinal cord dysfunction over time. This is the core idea. Early in the disease, symptoms often begin subtly, with numbness in the hands, abnormal sensations such as tingling, and gradual loss of fine hand control, which patients may initially overlook or attribute to other benign causes. As the condition advances, the neurological picture becomes more obvious, with worsening gait disturbance, increased muscle stiffness, limb weakness, and in more severe stages, involvement of autonomic control that affects bladder and bowel function. Progression is significant. On examination, key upper motor neuron signs such as brisk reflexes, Hoffman response, Babinski sign, clonus, and the inverted brachioradialis reflex provide strong clinical evidence of cord involvement and help support early diagnosis before permanent deficits develop. Recognizing these features early is critical because timely identification allows intervention before neurological damage becomes irreversible, making clinical awareness a central step in improving outcomes for affected patients. Early action matters. If you found this useful, join the Study Neuro community for more focused neuroscience teaching and clinical insights. You can follow along on YouTube, Facebook, TikTok, Instagram, X under @StudyNeuro and @StudyNeuroOfficial. Stay connected. Like, share, and subscribe for more high-yield neurology content, and stay tuned for the next session.